Here we go. Okay.
All right, I'm Becca Carl. I'm a sports medicine physician at Lurie Children's, and I'm going to be talking to you about soft tissue tumors. So this first case, this is an 8-year-old boy, and he presents with a history of left knee pain for 1 month, and it's severe enough to wake him up at night about 2 or 3 times a week. For the last 2 to 3 weeks. And his exam is remarkable for some mild tenderness over the proximal metaphysis. So let's start with Marcin. What are you thinking when you hear about this history? Anything else you'd want to know? What are your concerns? What kind of direction would you go with this?
So I would want to know if he has any fevers, if there's any trauma involved in this, a little bit more history.
Agreed. So his trauma history, very important. Fever, you mentioned constitutional symptom. So weight loss, certainly the history that he's waking up at night is a little bit concerning. I'm going to go to the next slide here, and these are his x-rays, and let's go with Sarah. I'm going to show you a close-up in a minute. So this is
It's got me getting in close on my
AP anolateral. And what do you think of these x-rays? When you see this, what are your thoughts?
It looks like I'm getting glare on my screen. It looks like there's something going on in the physis. It also looks like in the metaphysis, if I look back a little bit, it looks like there's some thickening there.
Yeah. Priya, what do you think? Do you think that whatever's going on here, do you think it's contained within the cortex, or would you say that this goes beyond the cortex?
I think it's within the cortex. I feel like I'm seeing something at the distal femur. I don't know if that's what I'm seeing, but I feel like I'm seeing some kind of like hyperlucency, or not lucency.
Here's the area that I worried about when I see this. And if you look really closely, you actually see this little shadow here that does go beyond the cortex. So does anyone want to make a guess? I'm not going to put anyone on the spot for diagnosis, but how about people call up differential diagnosis when they've seen this x-ray with this history?
Ewing.
I heard Ewing's is a good one. Anyone else?
I think Ewing would be my biggest concern for the age group and the presentation. But if there was some involvement up further in the physis, you could look at like a unicameral type of bone cyst, but it looks like it's migrated further. Like it looks like it's more in the metaphysis, and the stuff in the physis may just be from just normal irregularity in terms of the view there.
Yeah, so the physis actually is normal. I think this is just the projection and the physis, normal physes. But the area to me that's concerning is here. And when I look at this, this X-ray, the thing that I think about characteristics that would indicate something benign, and that would be something that is well contained within the cortex, which I don't think you see here. You see this, I don't know, is my arrow showing up here? Oh, there we go. You can sort of see these faint lines here of periosteal reaction. So this is whatever is going on here is expanding beyond the cortex. And if something is really slow growing, it will have sclerosis around it because the bone will have a chance to react to this and set up a sclerotic margin. But in this case, you really don't see any kind of sclerotic margin. You just see this sort of some vague borders here. Again, expands beyond the cortex. So whatever is going on, we know that it has some destructive properties. It's actually destroying the bone, and the periosteal reaction is just indicating that the body is trying to put new bone to heal this. So on my differential, when I see this, certainly malignancy would be really high up. You'd also want to think about infection, but this is a fairly indicative of the condition that this is. And anyone else want to call out a potential diagnosis here?
Well, it's definitely not, it's not a stress fracture. Somebody might want to call it that, but it's way too diffuse, I think.
I agreed, yeah, very diffuse periosteal reaction here. And you just see that the other thing is that there's a classic finding I'll talk about with osteosarcoma, and also you can see this with other malignant tumors, which is Codman's triangle. Does anyone remember that from medical school? Sound vaguely familiar? And the idea of that is that this is such a destructive process that you don't even really get great periosteal reaction setting up here. You just see little bits of periosteal reaction. You don't really have time for that to solidify and sclerose. So it looks very shadowy. You see a line let me just go back to the x-ray. I'm having a little trouble advancing my slides here. But here you see, usually with periosteal reaction, you see some uniformity. So you would see the line of periosteal reaction, and beneath it, you would see new bone here too. But you just see this faint shadow, and that's because this is so destructive, it's not allowing time for new bone to set up here. And we see this in the pediatric population generally. 8 to 25 are the most common ages. You do want to think about this though outside of these age ranges. I actually had a patient whose mother was diagnosed with osteosarcoma at 36, and her diagnosis was delayed because another provider told her that she couldn't have had, that she was too old to have osteosarcoma. These generally happen in the metaphysis, especially around the knee is the most common location, so distal femur and proximal tibia. And these tend to have lytic and blastic components. So when you look at the x-ray, you'll see some areas where it looks faint and there's bone destruction, and then you'll see areas where there's thickening and sclerosis. And then, as we talked about, these extend beyond the cortex, and they often have an extra osseous component. And so the kind of buzzwords on the boards, and when you read about these in the textbook, Codman's triangle and sunburst pattern, which is a similar descriptor. Here's an MRI picture of this. Even though these are usually diagnosed with radiographs and then often as part of protocols to determine treatment to see the extent of these. And about half of patients will have elevated alkaline phosphatase, which I think everyone's aware is a sign of bone destruction. But again, because it's only half, you can't rely on that as a sign. So here you see this sort of expanding into the soft tissues. And before I go, this was an actual patient that I saw as a fellow. Of course, this is the kind of thing you don't want to have walk into your sports medicine clinic. There's different, I don't want to go too much into treatment here, but the mainstays are chemotherapy, sometimes amputation, sometimes limb reconstruction. This boy actually had a treatment that was really interesting called the Van Ness rotational plasty. So the proximal tibia was basically, it's substituting the ankle joint for the knee joint. So they had to take out the knee joint, and then they rotate the ankle so that the ankle is backwards, and the ankle functions as the knee joint and can fit into a prosthesis. So instead of having what would be the equivalent of above the knee amputation and losing both the knee and the ankle joint becomes the knee joint, and then that sort of backwards foot and ankle becomes the knee joint and can fit into a prosthesis. And he did really well. So this next patient, this is a 16-year-old with a left groin pain for a month. And this adolescent participates in cross country, but doesn't recall any kind of injury, just had an insidious onset. And he notes that it's worse at night and after activity. And he's tried rest and ibuprofen, and those things do seem to help. He has no history of prior injury, or I should say trauma, not trauma. And he's otherwise a healthy boy. So, and on physical exam, he just has a couple little subtle things. The main things that you see on exam are that he has on the left side, the affected side, he's got very subtle quad atrophy, and he has slightly decreased hip internal rotation on the left, but his radiographs aren't normal. So let's see, who haven't I called on yet? Is it Jivan? Am I saying your name right? Or Jivan? What's on your differential here? What are you thinking about when you hear the story? You still on? Did we lose him? We'll go on to Anne. Are you still on?
Thinking about like femoral stress fracture, FAI, two things.
Yeah, I think absolutely. I'm going to give part of this away and say it's not a femoral neck stress fracture, and that makes sense because this is a talk about tumors. But definitely, when you have hip pain in a runner, you want to be thinking 1, 2, 3 femoral neck stress fracture. So that is a very good point. And here is the MRI, and I don't know, on my screen, some of can everyone see this on can you make this visible on your screen? Some of this is covered for me. So let's see. So again, remember that this is the left femoral, he's having left groin pain. So finding on the left. So let's go with, I have Jay, is that the UFC fellow? What do you think about this MRI? Do you see anything here that looks odd to you?
Yeah, you see that radiolucent, well circumscribed area right in the femoral head.
Exactly. What do you think about with this? Anything? So we've got a 16-year-old who's been having night pain, no history of trauma, relieved by nonsteroidal anti-inflammatories. What do you think about with this? Does that ring any bells?
Isn't it osteoma?
Yes. Right. Osteiod Osteoma. Here are a couple people chiming in. So, and then this is a CT picture. So in osteoid osteoma, it's a small benign prostaglandin producing tumor. And these tend to happen, it's actually a similar age range to osteosarcoma, so usually like in the 5 to 25 age range. And these produce prostaglandins, and so they tend to be really, the pain that these cause tends to be well controlled by non-steroidal anti-inflammatory medications, which suppress prostaglandins. So the treatment of this is to do an ablation, and I think I have slides of that, yeah. So this is a radiofrequency ablation guided by CT scan. So on the left-hand side of your screen here, you see this little osteoid osteoma, and then here you see this is a needle going into that area and ablating the osteoid osteoma. And so this is post-ablation, and you don't see much. I feel like it's not showing up great on here. There was like a very subtle, sometimes you can see the track of the needle after the ablation. And this is just showing, these actually can happen in any bone. This is showing one that was in a vertebrae. You can see here, they have this classic appearance that's described as being like a bullseye. So these don't always show up in x-rays, but sometimes they will. And you see this little sclerotic nidus here, and then a surrounding clearing. So again, these are common. They're a little bit more common in boys. They produce prostaglandin, and these actually can recur. And as it turns out that young males are the most likely to have recurrence of these. I've seen, a handful of these in practice. Maybe a year ago, I had a boy came back 28 months after his initial presentation with recurrent hip pain, and he had osteoid osteoma that had recurred, and he underwent ablation a second time. So just something to be aware of, that these can come back. It doesn't mean that they're malignant. And here's this is a picture I showed you earlier. So this is the nidus actually over here. These are often visible on plain radiographs. Sometimes if they happen in the vertebrae, you can get almost like a little reactive scoliosis because of muscle spasm. The classic, some of the old studies will talk about using bone scan with SPECT to diagnose these, but the test that's considered the gold standard is a CT scan. Now, honestly, practically speaking, we often get MRI, and I can't remember who it was who said, I think was it Anne who mentioned femoral neck stress fracture. So depending on location, you may get an MRI to look at other conditions that are on the differential diagnosis. And they often cause a very broad pattern of edema surrounding this little target area. So the treatment for these is, one option is that you can just treat these symptomatically, and they will eventually heal spontaneously, but it can take years. So again, one option is you just have patients treat with non-steroidal anti-inflammatories, and if that controls the pain, that's certainly an option. Much more common, though, is we have these T-guided ablation, as in the case that I showed you. And then occasionally, if it's really hard to reach area, this is showing for that one that was in the vertebral body, this patient underwent surgical excision, because the radiologist was concerned about reaching this percutaneously. So, and there's another type of tumor that's very similar. It's called an osteoblastoma. And an osteoblastoma is basically the same thing as an osteoid osteoma, but it's bigger. And so if it's over 1 centimeter in size, we call it an osteoblastoma. And once they get to us, probably what happens is that these start as osteoid osteimas, they have to start somewhere, and then they get bigger. And so these are the ones that are sort of locally destructive. So as it turns out, though, the bigger ones cause less pain, but are more likely to be resected because they can continue to get bigger and cause local destruction, and also they tend to not be so responsive to non-steroidal anti-inflammatories. So just remember that osteoblastoma is basically a giant osteoid osteoma. So I'm going to shift gears here and talk a little bit about cartilaginous tumors. The first, this is an enchondroma, and an enchondroma is actually not really a tumor. This is leftover epiphyseal growth cartilage that persists in the metaphysis. And these usually become apparent either because they're either found incidentally if a child has an injury and has generally happen in the hands and feet, especially in the phalanges. So again, these are not so concerning, but you may see one incidentally. And there's a condition called Olliers syndrome, and for anyone who's peds trained, probably this is something that comes up on the pediatric boards. Olliers is a syndrome of multiple enchondromas. So, and the characteristics of these on radiographs, they have this expansile nature. But if you think back to the osteosarcoma that I showed in the first case, these actually, that one actually went beyond the margins of the cortex. But here, here you can see that. Let me keep advancing my slide. You can see here that the cortex is actually preserved here. So these sort of expand and they push out the cortex, but they actually do not go beyond the margin of the cortex. And that's a really important feature when you're trying to distinguish benign versus malignant. So again, these are well defined. They are mostly lytic. Sometimes you'll get a little, so they look dark on X-ray, and they sometimes will have a little bit of internal calcification in them. So, all right, so another case, so my chance to call on somebody who I've missed. A 12-year-old girl presents with a bump over the medial aspect of her right knee, and she noticed it several months ago. And she says it's not painful exactly, but she gets some irritation when something hits it. And she feels like this is a little bit, I apologize for the grammar on the slide. She feels like the bump is a little bit larger than when she first noticed it. So is it Gary? What do you think about this story? What are you thinking when you hear this story? What would be on your differential? 12-year-old with a pretty minimally symptomatic insidious onset of a bump over the medial aspect of right knee. Any thoughts?
Well, could be a number of different things. Just a bump that's tender, huh?
Yeah. What would be your first step in evaluation? We'll start with that.
Well, examine her, see if she's tender, get some plain films.
Yeah, so physical exam, she has a pretty obvious 3.5 centimeter palpable nodule. It's fixed, it's firm. It's over the distal femur, and I'll show you her radiographs. What do you think of this?
Well, there's definitely a cortical, there's definitely a bony prominence over there on the medial aspect.
Yeah. And does this look like something that would feel 3.5 centimeters for you? Like, what do you think in terms of, clinically you notice something that's 3.5 centimeters. Do you think that's consistent with what you see on the X-ray here? Or do you think
no, this looks a little bit bigger.
Yeah. So actually these tend to feel bigger. I'll talk about why, but these tend to feel bigger on palpation than they actually look on radiograph. So anyone want to chime in about what they think this is? What do you think about if you see this? So you've got a 12-year-old, I don't know if I said this, but no constitutional symptoms.
Osteochondroma, maybe?
So this is exactly an osteochondroma. And there's several names for an osteochondroma. The most common two are exostosis and osteochondroma. And these usually present as a painful mass. And the mass is actually, it's continuous with the cortex, and they have a cartilage cap, and it almost acts like a growth plate. So as kids grow, this will grow also, and it'll have a cartilage component that can't be seen on X-ray. So one of the things about these that's sort of classic is that you look at the X-ray and you think, boy, that looks sort of, I see this little thing on X-ray, but when I feel it, it feels like a ping pong ball to me. But on X-ray, it looks more the size of a marble. That would be really consistent with an osteochondroma. They feel bigger than they are. So if you look in the textbook about this, they'll say that they can enlarge up to age 30. I would say that, to me, if I see somebody who's in their early 20s and they still have this enlarging, then they should think about resection. I think of this like a growth plate, and certainly there are areas like the clavicle or some of the growth areas around the pelvis that can continue growing into people's early to mid 20s. But 30 to me would be sort of old, even though that's what the textbook answer is. So if I had a patient who was in their 20s and they had continued growth of an exostosis, I would probably refer them to surgery. And these really persist. There's reports of them getting smaller or regressing, but mostly they just sort of, they are what they are. You have them. And this is a radiographic diagnosis. Usually don't need any other studies. Again, the classic finding here is that they appear to be completely continuous with the underlying bone. So the first one I showed you, that was what we would call sessile. It's got a broad base. And this one is what we would call pedunculated. So it almost looks like it's arising from a stalk. And these do have a very slight malignant potential. And I think of it this way, is that, any tissue essentially that's where you're getting growth has malignant potential, right? Anything could become cancerous. And these tend to probably grow a little faster because they have their own cartilage cap. They almost grow like a growth plate grows. These grow a little bit faster. And so it's very rare, but you can have malignant degeneration of an exostosis. But if you have multiple exostoses, which is a hereditary condition, then the chance of malignancy is actually a little bit higher. Now, people who have multiple exostoses, these can be really hard to reach. So they don't usually just remove them all. They remove the ones that are really symptomatic. And it's very uncommon to have this as part of a syndrome. It's much more common just to have a single isolated osteochondroma exostosis. And the general rule is if it's in a young person and it's growing, or if it's an older person and it's not growing, they don't need to be removed unless they're causing symptoms. And I'll say that clinically, it's really interesting that I've had kids who have these where they look just enormous. And the kids are fine, and they say, I don't want to do anything about it, just leave it alone. And then I've had a couple kids where they have what looks like a teeny tiny one. I had boy recently, he had, I mean, it looked on x-ray, it was like 5 millimeters. It was in the posterior femur, back of in the popliteal fossa, and it really bothered him. And I think they decided eventually against having it removed, but initially he just because the surgery was high risk, they decided not to do it. But it's funny, it's not, the size of these isn't always what causes symptoms, it's sort of where they are and probably the activities that kids do that determine how symptomatic kids are. So this next tumor, a cartilage tumor, is Chondroblastoma, which is known as, we talk about Codman triangle, but there's something called Codman tumor. And this is, it's technically a benign tumor, but it can be very destructive locally. And these can look a little bit like OCD, but the key thing is that they're not really adjacent to the articular cartilage. So you see here, this is sort of hard to see, you see this lucency, but it doesn't quite meet the articular cartilage. And sometimes these can have a, you know, if you can imagine that if this was a little bit lower in this distribution here, it might look more like an OCD. I sort of have a running joke with one of our musculoskeletal radiologists, because I tend to see these in places where they don't exist. So I'm always calling our muscular radiologist and saying, hey, Jonathan, what do you think? Do you think this could be a chondroblastoma? And I think he sees my name on his call, on his cell phone, and thinks he probably just wants to text me. It's not a chondroblastoma. So, all right. So I feel like I'm gonna just for a second stop sharing this, and we're gonna take just a 2-minute break, because this is sports medicine and I want everyone to have like a physical activity break. We're all stuck inside. So I'm gonna ask everybody to turn off or cover their cameras if they want to, because this is gonna involve dancing. And I'll tell you that I'm certainly gonna turn mine off. And we're going to do, this is, if anyone hasn't seen this website, it's a great website. It's Hip Hop Public Health, and they have 2-minute dance breaks. And so, let me see, let me share.
I will stop the video as well.
Okay. Stop the video here for a minute. Let me make sure I can find it. Here we go. Okay,
people might want to mute themselves also if they're really getting into it.
Cover my video as soon as Yaz bounces done. We'll do the video. All right, we'll resume in 2 minutes and 11 seconds.
What's up, everybody? I'm LaShawn.
And I'm Mark.
And we are breaking it down. Today, we're going to do the yes bounce. And you can do this seated like my boy Mark, and you can do it standing up. Either way. Yes, and you can just breathe, relax for a second. You're going to take your head up and down like you're saying yes. But right here, you go up, down. Up, down. Yes, up and down. Saying yeah. Up, down. Okay. And down. Good. Make sure you bring that chin down, right, looking at yourself in the mirror and saying yes. And yes, good. Good. Get to feel the rhythm of that head there. Then you're going to go a little bit faster. And down, down, down. What? Okay, yes. And down. Pull it down. Good. Stay right here. Feel the beat. Now we're gonna do it 4 times. Gonna look that way when you go. And you're 4, 3, 2. Other side and 4, 3, 2, and go. You just walked in the room and what they say. Yes. And 4, 3. Just go 2 each side and 1, 2, and 1, 2. Good. Keep moving. What you're saying, yes, I'm great. And yes, I'm fabulous. And yes, give me 2 more right here. Make it good. Let me see that last one. What? Good job. You just did the yes bounce. Have a great day. Keep dancing. Up and down now. Bounce, bounce.
All right, everybody can turn their cameras back on. We'll resume the presentation now that everyone's gotten a little physical activity break. All right, so we finished chondroblastoma. And we'll go to, oh, we didn't finish. I take it back. So this is just showing another example of chondroblastoma. Again, this is, you see this lucency here with the, in this one you have a small focus of calcification, which is not always seen. When you do have this, it's best seen on CT scan. MRIs can help elucidate this diagnosis. You'll often see surrounding edema. And as I mentioned, it can be mistaken for an OCD, not so much in this location, but you can see that if it was in the distal femur, especially if it was more this type of distribution, more centered in the middle of the condyle, you could mistake that for an OCD, but these spare the bone that's immediately under the chondral surface. So that's how you distinguish. And again, these are locally destructive, and so the treatment for these is that they get curetted out. And these should really be seen by somebody who knows what they're doing, because there's a high risk of growth plate injury in younger patients, so especially in the pediatric population. This should be seen by somebody who has a lot of experience, not necessarily just pediatric orthopedics, but pediatric orthopedic tumor, adult tumor. And then this is a sort of similar looking tumor. So I said most of this talk was focused on pediatric patients, adolescents, and young adults, but this is one that I shouldn't say we because I don't see adults, but is generally seen more in the adult age range. I'm just realizing I didn't uncover my camera after the dancing. These tend to be radiolucent. They have this eccentric appearance, and they're in the epiphysis, and these are also locally aggressive. So these really behave a lot like chondroblastoma, but they have a higher malignant potential. So I'm going to move on to talking about fibrous lesions, and now I've got another case, so I think I've got a couple residents that I haven't called on yet. So a 13-year-old girl comes into the sports medicine clinic, and she had an ankle sprain a week ago, and she's really limping, and she's having some difficulty bearing weight. So you get some x-rays, and you find this incidentally on x-ray. Adam, what do you think about this?
I mean, it's not extending outside the cortex. I mean, you have some radiolucency. I mean, it kind of looks like non-ossifying fibroma, really, to me.
Yeah, excellent. So one feature here that we talked a little bit about is reassuring is that there's this sclerotic rim of this. So when you see sclerosis, it means that the body had time to set new bone up around this, and so it cannot be an extremely fast-growing tumor when you see this. So this is, again, you brought up a great point. It doesn't extend beyond the cortex. It's got a sclerotic rim here, and this is, you're exactly right, this is a non-ossifying fibroma, which is also called a fibrous cortical defect. And these actually, when they've done skeletal survey studies of children, about 40% of kids will have a non-ossifying fibroma in their skeleton. And that's really important because, so I see only children in my practice, and I basically sort of see right through these. If I see a little one, it barely, to me, it's like a freckle. It's barely worth noticing. But now in the age of my chart, where parents can get their reports, and the radiologist sometimes comments on these, and I don't always, then I make sure if I see one of these that I explain to parents. I just say this is like a little piece of scar tissue in the bone, and it's nothing to worry about. Because I once had a family call me really concerned about this. They read the report that mentioned this fibrous cortical defect and wanted to know what that was. And I just want to remind everybody to mute if you're not on mute, unless I call on you, then you can unmute. And we see these typically between the ages of 4 and 8. They can happen anywhere, but mostly they happen around the knee, especially the distal femur. And almost always they're found incidentally. There's not a high risk of there's no real risk of pathologic fracture. That being said, the conventional wisdom is if they take up half of the width of the bone, that you should consider having them removed. I've actually never, I see these all the time. I've never had one that required removal. I think once I sent one to Dr. Peabody, and they just watched it every 6 months or so. This is a kid who had a pathologic fracture, but that's extremely uncommon in non-ossifying fibroma. So if you look in the textbooks, they'll recommend that you follow these every 6 months. But I just want to make sure everybody's muted. But I will say that in practice, almost none of us follow these unless they're really large. So this next lesion, this is a fibrous dysplasia lesion, and this is something for whatever reason tends to show up on the pediatric boards a lot, although not the sports medicine board so much. But this is also a defect in bone formation and not a true neoplasm, and usually they just happen as a single lesion, and so we say that they're monoostotic rather than polyostotic, and these tend to happen incidentally, be found incidentally or with a pathologic fracture. And this location here in the proximal femur is a very common location. And so the downside to these is if you find these in this location, you really need to be worried about the effects of having like a subtrochanteric fracture here, or femoral neck if they extend up higher. So these can happen in any bone, but proximal femur is very common, as is rib. Rib not so concerning in terms of function and risk of pathologic fracture. These often get treated surgically. And the classic, if these show up on the boards, the classic description will be that it has a ground glass appearance. And so again, these can be treated with curettage and bone grafting if they're in a high risk femoral neck. So somebody mentioned earlier when we were talking a unicameral bone cyst. And a unicameral bone cyst is often called a simple bone cyst. Once I heard a great lecture by Jim Wright, who's at Sick Kids in Toronto, and he said, these are so difficult to treat. Why does everyone call them simple cysts? And since then, I've pretty much stuck to saying unicameral bone cyst. And the classic locations of these are the proximal humerus and femur, about 90% of the time. And generally, these are found with a pathologic fracture. So Joe, any idea about what's a classic finding of a unicameral bone cyst? There's one that's like, it's like the textbook answer. You know what you would say for a unicameral bone cyst? I gave you a really tough question, so if anyone wants to help him out. There's a sign of these that's really pathognomonic. It starts with the
Don't they call it a bubble?
Actually, it's a fallen something. Does that ring any bells for anyone?
Leaf.
Falling or fallen.
Falling leaf sign.
Yes, a falling leaf sign or a fallen leaf sign. So the idea is that these, basically they're like these hollowed out cysts, and you can have a little piece of bone within and they're fluid filled, and that piece of bone, it will sort of float down to the bottom of the cyst. And so here this arrow is showing a fallen leaf sign. If you see that, that's classic. You know when you see a fallen leaf sign, you've got a UBC. And these will be surrounded by a thin rim of bone. They tend to be adjacent to the epiphyseal plate, and they extend into the metaphysis. And again, fallen leaf sign would be classic for these. So there used to be this thought that they would just spontaneously go away and fill in with bone, but there's been several papers looking at the natural history of these, and they really don't seem to go away very frequently. Spontaneous regression is very rare. What can happen is that as you grow, the cyst will mature and sort of grow. The physis is cranking out new bone, and so it will actually sort of send the cyst away from the physis, and they may be less likely to cause pathologic fractures. So when kids have a pathologic fracture, or there's thought that this could be high risk for pathologic fracture, then the treatment is surgery. One of the treatments that's been used quite a bit is to use expensive bone graft materials. Those have not been shown to increase the rate of healing.
I haven't learned anything I don't know yet.
These get curetted out, and you can put some steroid in there that may increase the healing rate. So aneurysmal bone cysts, these can be confused with unicameral bone cysts. If there's anything that would be high in the differential diagnosis when you're looking at a cyst like this, it would be an aneurysmal bone cyst. And these can happen with other, in conjunction with other tumors, like chondroblastoma is a common one. We see these 80% of the time are in teenagers. And so unicameral bone cysts, they usually are either found incidentally, or they become acutely. On the other hand, they don't usually have pathologic fractures. They tend to have. I'm hearing a little bit of background noise, so I'm just going to remind people, if you don't have your microphone on mute, please mute for us. Thanks. But people with and aneurysmal bone cysts, they, like unicameral bone, they're radiolucent. Unlike UBCs, they're actually a little bit eccentric. And they will have often a thin shell of periosteal reaction around them. And if there's confusion about whether it's an ABC or a UBC, a CT scan can be really helpful in distinguishing between these. And ABCs are filled with blood, whereas UBCs are filled with fluid. So, and then the last tumor I wanted to cover is Ewing sarcoma. This is similar age distribution to osteosarcoma. We usually see these in patients between the age of 5 and 30. And these, the most common presentation of Ewing's is that it's a primary bone tumor that has a soft tissue component, although these can be primarily in the soft tissue as well. And the Ewing sort of family of tumors, it actually has to do with their genetic makeup, what classifies something as a Ewing sarcoma. And these will cause diffuse bony destruction, and you can see that here. So this is, we talked about with the first case, the things that are concerning is really like a heterogeneous appearance, something that expands beyond the edge of the cortex. You see periosteal reaction, and then this sort of a little bit of a mixed blastic and lytic component. So this X-ray, even if you don't know it's Ewing's, this would be really concerning for malignancy in this, as we see in the slide. So, and with Ewing's, you see a lot of inflammation and big soft tissue components. So here you can see that this extends beyond the bone. So, all right, so that's all I have. I'm going to stop the video here and I'll take any questions. And if not, do we have time to hear about bronchospasm? All right. Thanks, everybody.
All right. Thank you very much.